Okay, welcome. We're going to start the session. A warm welcome for everyone here. There will be people joining us a little bit later because of the program not keeping on time, but we'll try to manage within the time given to us. Thank you for being here at the session on innovative strategies for care and improvement and development of psychosocial interventions in care in young onset dementia. My name is Kirsten Bakker, program lead at Radboud University, the Netherlands, on young onset dementia, and together here with Marjolein the Vugt, co-lead. And well, that's the introduction of myself. Marjolein, can you say who you are?
Yes, my name is Marjolein de Vugt. I'm the chairperson of INTRADEM, a research network on psychosocial research in dementia. And we're very happy that Alzheimer Europe facilitates this session dedicated to INTRADEM. And I'm a professor in psychosocial innovations in dementia in Maastricht, Netherlands. Yeah, we have, I think, a very nice lineup of speakers today. And the first speaker is Dr. Kirsten Peetoom. She works in Maastricht, in the Netherlands. And she's a postdoctoral researcher at the Alzheimer Center there. And her research focuses on psychosocial aspects in young onset dementia. And she has been involved in various projects, for example, on working with dementia, but also projects on developing online intervention programs for caregivers of young onset dementia. And today she will talk about a national study called PRECODE.
Yes, thank you. Today I will give you a brief overview of the Dutch PRECODE project that lasted between 2018 and 2022. I was part of the coordination team together with project leader Marjolein de Vugt and Christian Bakker. Dementia at a young age has a profound impact on the people involved. The research shows that the care is not appropriate, and also the time until diagnosis is long. So the PRECODE project aimed to improve the care for the young onset dementia, and also to improve the time until diagnosis. So to develop this appropriate care for this target group, the PRECODE project aim to, sorry, I'm a bit disturbed now, obtained insight in the terminology and underlying cause of a young onset dementia, on acquiring accurate data on the occurrence and characteristics of young onset dementia, and gaining insight in the early symptoms and also the care pathways. PRECODE was a project by the 4 Alzheimer Centers in the Netherlands. So we joined the forces, and together we conducted several work packages. The first work packages focused on the terminology and definition of young onset dementia. The second on the global prevalence and incidence of young onset dementia. The third on the 1-year prevalence. And the fourth focused on setting up a national database in memory clinics. The last one focused on the pre-diagnostic symptoms and post-diagnostic care in the GP practice. So the first work package aimed to provide recommendations for the terminology and definition of young onset dementia. They did a literature review and they searched literature on the terminology, age-related aspects and etiologies underlying young onset dementia. They included 89 publications, and what they found was that young onset dementia was the most preferred term in the last 2 decades to denote this target group. Also, they found that the upper age limits of 45 to 70 years old was also the preferred cutoff age. Next to this, they found that 251 different etiologies were seen as a possible cause underlying young onset dementia, and also they found 27 categories of this. If you want to read more, you can read this very nice paper on the review. And next to the review, they also conducted a Delphi study on the terminology and definition to reach the consensus. And to achieve this, they conducted 3 rounds with 44 experts to reach the consensus, and they responded to 35 statements related to terminology, age-related criteria, and etiologies. They reached full consensus on 22 out of 35 statements, and if you can see, the young onset dementia was the most preferred term. They achieved full consensus on this. Also, the symptom onset of before the age of 65, they also reached consensus on. And next to this, also 50 out of 22 etiologies and categories of etiologies was also where they reached consensus on. This Delphi study is also published. Also, if you want to read more, for more details on the methods used and the results, you can read it. In the next work package, we focused on estimating the global prevalence and incidence of young onset dementia. A large systematic review and meta-analysis was conducted, and to estimate the global prevalence, 95 unique studies were included. And to estimate the global incidence, 61 unique studies were used. Based on the meta-analysis, a global prevalence of 119 persons per 100,000 people was estimated. This can be translated in 3.9 million people worldwide living with the young onset dementia. And for the Netherlands, this can be translated into 14,000 to 17,000 people. What you can see on this map is that the spread of where the studies are conducted is varies largely. You can see the most studies were executed in America, Europe, in Asia and Australia. But also you see the white spots. This is where the numbers are lacking. Also, the second review focused on estimating the global incidence. They found an incidence of 11 per 100,000 people, which can be translated in 370,000 new cases every year. And here you can also see that most studies are conducted in America, Europe, and one also in India. These results are both published in journals with high impact. The next work package focused on obtaining insight in the regional prevalence of young onset dementia in the Netherlands. They executed a prospective study, and patients were included with a symptom onset before the age of 65, or they received a diagnosis before the age of 70. They registered this in two regions, in the Rotterdam area and in the Eindhoven area. In Rotterdam, they found a prevalence of 41.6 per 100,000 people. And in Eindhoven, they found 36.6 per 100,000 people. Here you can see it also more visualized. You see that most people who were included were above the age of 65, below the age of 70. But you also can see that in Rotterdam area, more people have vascular dementia compared to Eindhoven. Also, you can see on the right, in the tables or in the figures on the diversity, that you can see that the migrant population is probably underrepresented. And also, the registration was during the COVID pandemic, so probably the real prevalence is higher. In the next work package, they focused on setting up a national database on patients with young onset dementia in memory clinics. They collected data in local memory clinics and for patients with the age who had the diagnosis before the age of 70. A total of 39 hospitals included patients and a total of 781 persons with dementia. You can see that Alzheimer's disease was the most prevalent diagnosis, and that the people with frontotemporal dementia were the youngest in age. Also, what you can see is that over half of the persons were experiencing their symptoms longer than 2 years. These results and the methods used you can also find back in this nice paper, just recently published. In the last work package, we focused on obtaining insight in the pre-diagnostic symptoms in the GP practice and also in the post-diagnostic trajectories. To obtain this insight, we dove in a large GP registry with 89 people with young onset dementia and all the written notes and the medical files. And they were matched with 162 controls. What we found is that when you look back on the diagnosis, 5 years preceding, that the cognitive symptoms were appearing first in the medical records, followed by affective symptoms, social symptoms, behavioral symptoms. And in the last year, what we saw is that there was more reports on decline in daily functioning. Also, a nice paper is written on this, so if you want to read more. And the final one is that we looked into the post-diagnostic care trajectories. 75 persons were included in this analysis. And what you can see is that more than 2/3 of the persons made use of a case manager. Over 40% attended daycare, and almost half were also institutionalized. So we also looked into the written notes in the in the medical records, and also we saw that there were also reasons for initiating care or reasons for withholding care. Also on this, we have a nice paper to read more on the methods and the results. So within the PRECODE project, we found it very important to also focus on the dissemination. So during the Alzheimer conference in The Hague in 2019, we already organized a symposium on PRECODE. What you already saw, we have a lot of scientific publication, but also the results found their way in book contributions and also content for YOD-specific education. This is the list of the PRECODE publications, and also one is still in progress. So what have we learned within the PRECODE project? What we saw is that, especially for when you want to register or build up a database on people with young onset dementia, the motivation, time and input are very dependent on healthcare professionals, especially for the inclusion. So to invite people to use their data in the databases, but also the data entry was really dependent on the medical doctors who have little time to do this. Also, what we saw, you're really dependent on driving forces, and especially when they change their jobs, it's really difficult then to keep on going with your research. Also, COVID-19 impacted on these studies, and especially when prioritizing to contribute to the research or have other priorities. Also, PRECODE is a strong basis for further research projects and collaborations. So within the Abort project and YOD-INCLUDED, they're also looking into the building up databases with data on people with young onset dementia, and also still striving to optimize the care, and also to see if we can improve the time until diagnosis in the GP practice. I want to thank all the researchers involved and with all the research centers, and I'm looking forward to all the research projects we'll continue together.
Okay, thank you. Really quick overview of very extensive projects, so I can imagine there are some questions, some people dropping in later. Also, welcome to this symposium on young onset dementia. This is also a hybrid session, so there will also be people online watching. There's opportunity to ask questions online or here in the room. There's no questions yet here coming in from the people watching online. So maybe here in the room, I can imagine that people have questions about what is presented. Who dares? No questions. So, Kirsten, can you a bit reflect on the most important clinical implications of the work that has been done in the PRECODE study? Is there anything that we can already implement in a clinical setting, or is useful in that context?
What I think is very useful, what you already know, is that we have more insight in the pre-diagnostic symptoms. We know what the symptoms are for young onset dementia, but we didn't know before how they present to the GP or to the GP in the GP practice. But it's not enough for this to already have like, oh, really keep an eye on this, but it's a really important first step for the clinical practice to shorten the time until diagnosis. But what I also think is that the PRECODE project also had a good contribution, I think, in raising awareness for this target group in the Netherlands. It's also what you see with the continuing with the research. So I think that's already important implication, but also that we now know in the memory clinics what are the characteristics of the people presenting. So also we can optimize care in the clinic.
Okay, thanks. Thank you so much.
Okay. And then we go on to the next speaker, all the way from Australia. Professor Muireann Irish is a cognitive neuroscientist based at Frontier Research Group at the Brain and Mind Center at the University of Sydney. And Muireann has long-standing interest in the mechanisms that drive cognitive and behavioral changes in young onset dementia and how we can use this knowledge to improve quality of life for those affected. And she has won several prestigious prizes, so we are very proud to have her here. Muireann, the floor is yours.
Thank you so much. So you'll have to forgive me because it's about midnight in Sydney and we only arrived yesterday, so I'll do my best. But it's a great pleasure to be here and to represent some of the work that we've been doing at the Frontier Research Group in Sydney, which was founded by John Hodges, who's one of the pioneers in younger onset dementia. And so this is going to be an overview just of a single study. But I think what it shows is how we have identified a new feature that previously wasn't really given a lot of credit in younger onset dementia, and then working with people with lived experience, how that enhanced our understanding of this symptom and actually led us to be able to develop some new interventions to support people who are in a caring position either in the home or in the residential aged care sector. And so this work is presented on behalf of Frontier. We're based in Sydney, and we cover pretty much the spectrum of younger onset dementia, focusing on frontotemporal dementia. And many people here will know that there are a number of different variants. Today, I'll be mostly talking about the behavioral variant of FTD and semantic dementia. And so one of the features that we have been really interested in is this idea that there are certain behaviors that seem to manifest in younger onset dementia that can be attributed to a disruption of reward processing. And by this, I mean the way in which the individual is approaching or actually deriving pleasure from rewarding experiences. And this can manifest in a host of seemingly unusual behaviors, but actually when you think of it from the perspective of reward, they actually make a lot of sense. And so we see these characteristic changes in eating behavior, in the approach to eating and meal times, in the interest that people show in hobbies that previously might have been enjoyable. There's a dampened response to these pursuits. We see changes in sexual behavior, in intimacy, in financial capacity, insensitivity to loss, so this can lead to sort of problematic spending or gambling, and the emergence of stereotypies and rituals. And so Christina Horn, who's a postdoc in our group, has a poster on how some of these rigidity and ritualistic behaviors might emerge. So that's poster 37 this afternoon. And so one area that's been a major focus for our team is to look at how motivation changes in younger onset dementia. And while there are many behaviors that can be quite troubling for the person living with frontotemporal dementia and their families, these sort of reduced or negative behaviors, as in there's a loss, can be actually really disruptive. So the person may lack drive to get up and go. They may be unable to initiate behaviors or actually unable to engage in activities that they would like to, but don't have that impetus or that push to be able to do it. And so apathy is it's multidimensional, and it's actually highly predictive of functional decline, carer stress, as well as patient admission to residential aged care and mortality. And so this has been given quite a lot of airtime, if you like, in the research community. But there was another symptom that I was particularly interested in, which is the loss of pleasure, or anhedonia. And so this is a symptom that's typically discussed in relation to depression or other neuropsychiatric disorders. But in fact, when you think about many of the disruptive changes that occur in frontotemporal dementia, it's really surprising that this symptom or this feature was never discussed in this context before. And so I was really interested to understand, how does anhedonia, this loss of pleasure or a lack of interest in activities and pursuits that the individual used to find pleasurable, how does this manifest in FTD? And is this something that we should actually be putting on our diagnostic radar? So for me, this was something that I thought has been overlooked perhaps in relation to FTD. And when we thought about it on the neural level, many of the brain regions that are implicated in FTD are actually highly relevant in the brain's reward circuitry. And so it actually made sense in terms of the clinical presentations of people living with FTD, the underlying cognitive mechanisms that we know that are disrupted, as well as the neural regions that we know are impaired. So there was all of this converging evidence pointing towards this likely being a factor that might give rise to some of these behaviors that we see. And so we conducted the first study back in 2021, and this was the culmination of 7 years of data collection. So these samples take a long time to collect, and we worked very closely with our people with lived experience and their families. And we found that in FTD syndromes, particularly in semantic dementia and in the behavioral variant of frontotemporal dementia, that anhedonia was actually a very prominent feature. And that this had been sort of overlooked in the whole dialogue and conversation on FTD. We also found that apathy co-occurred with anhedonia. And so we were interested to see on the neural level, can we actually distinguish between these two symptoms? Because they're highly overlapping. It makes sense that if you have changes in motivation, you might also have changes in your pleasurable response to stimuli. And we found that actually they're driven by distinct neural substrates. So there are different regions in the brain that are affected by the underlying FTD pathology that are differentially contributing to apathy on the one hand and to anhedonia on the other. And then we found that in younger onset Alzheimer's disease, we did have this group were presenting with apathy, but not with anhedonia, meaning that they were still highly responsive to pleasurable activities and experiences, but just didn't have the drive, perhaps, to seek them out. So it was giving us informative insights into how we might actually remedy some of these changes and better support the person affected. So in the aftermath, we published this study in Brain in 2021, and what really surprised me was just how strongly this resonated, not only with the scientific community, but actually with like the broader media and the public. And so there were all of these, you get these usual headlines, dementia, the pleasure system is, wasting away, and it just seemed to capture that broader imagination of the general public. And I think it uncovered a symptom that to me is quite poignant, because a life without pleasure is actually something that's quite, it's very sad for me personally to think about people not being able to enjoy their pursuits or their hobbies. And so we had a lot of media interest, a lot of, interviews and, TV interviews and online awareness campaigns. But what really resonated with me was that we had members of the general public emailing me and telling me, this is what I needed to know back when. And so I got so many emails from people saying, I wish I had known about this symptom because I thought that my husband no longer loved me. I thought my husband didn't care about our family anymore. Someone was saying that they realized this was one of the earliest changes that happened years in advance prior to the more obvious, maybe behavioral changes, and that they were struggling to articulate or to label what was happening with their loved one. But actually, finding out that there was a name for this and it was something definable actually helped them to better understand what might be happening. And so because of this, I really thought, well, we need to understand and maybe develop some kind of supports that might help not only raise awareness of this as a very neglected feature, but also help people to understand and perhaps manage and navigate these changes in a better way. And so at Sydney, we have set up a group called the Sydney Dementia Network Lived Experience Expert Advisory Panel. So we call it LEAP because it's a bit of a mouthful. But basically, LEAP is a group of 16 to 18 people who are living with a dementia diagnosis caring for someone with a dementia diagnosis or have been a carer in that situation. And so we meet quarterly, we all gather on Zoom, we send out the materials to our panel in advance, we print it off and post it out, we give people time to, you know, read through what we plan to discuss, and then we come together and have these meetings where we discuss grant applications or how to disseminate information in a way that's more accessible. And it is such a valuable resource, and I wish we had set this up many, many years ago. So I pitched the idea that we needed to do an awareness campaign and to develop some educational resources for people living with younger onset dementia, and just to raise, you know, the collective awareness around these symptoms. And so all of our members agreed that this had been a completely neglected topic, and many of them found that it resonated with them, some of the changes that we were describing. They emphasized the importance of perhaps developing some sort of, you know, psychosocial, educational or interventions to support carers in the home, but also in the aged care setting, because I think there was a tendency for people to possibly think, oh, you know, if they're just sitting quietly in their room, they're happy doing that. And a lot of misattributing loss of motivation as the person being happy just to be left to their own devices. And so our research is sort of suggesting that, in fact, that may not be the case, and we might need to do better engaging people. And so the importance of trying to develop strategies that are suitable specifically for people living with younger onset dementia. And so with that in mind, we actually co-designed a new educational toolkit tackling loss of motivation specifically for younger onset dementia. And again, this was like a really important learning experience for me to work and co-design with people living with younger onset dementia and with their families, phrasing things in the appropriate way, getting the right examples, and understanding exactly how these symptoms are impacting the people who are directly impacted by them. And so this has been really, you know, surprisingly again, it shows the need for these type of targeted toolkits. It was downloaded all over the world. We've been promoting it heavily on social media, and we're now in the process of translating it. We've done a version in Mandarin, which has gone, you know, we've disseminated that in China. We're working with the BrainLat community in Latin and South American countries to try and develop a more culturally appropriate version for there. And it's really shown how there was such a gap in knowledge and that we really needed to fill it. And I think the only way we could have done this was working with people with lived experience. We also decided to go a step further, which we've literally just launched for World Alzheimer's Day. And so we thought, I've received some feedback from carers working in the aged care sector saying, I did not know that motivation was a problem in dementia, and that they were sort of reappraising their approach to people living with dementia and realizing that they were misinterpreting a lack of interaction as, you know, the person is fine and they're just quiet. And so we decided we needed to actually develop some recommendations and again, help people who are working in these positions to try and understand what this withdrawal and this sort of apparent loss of interest actually really reflects. It's a problem that has a biological origin in the brain, and that we need to be able to actually reach out and make sure that we're engaging people appropriately. And so we ran some professional development seminars. We also launched a white paper with very tangible recommendations for how to approach these scenarios. And eventually, just last month, we launched this aged care guide, so to tackle loss of motivation in the aged care sector. And so we worked with Dementia Support Australia, who are like a national centre that provide resources and training for people working in the aged care sector. And as part of this, we developed a poster that can be put up in the aged care tea room or, you know, the setting where staff congregate. And
1 minute.
We also have a QR code that they can download, so they have their own version on their app or their device. And we're still building in this feedback mechanism. So we have a survey through the QR code that you can actually give back. And we've asked specifically, is this helping you in your care? What have we missed? And I think it's just staying open to knowing that you can't, like I can't know what's going on in the aged care setting. I need them to tell me, and then we can keep going and try and revise and iterate as we go. And so looking ahead, what we're going to try and do next is to see how some of these symptoms might actually differentially manifest depending on your context, your background, and your culture. And we want to make sure that we're actually staying attuned to how these loss of motivation and their various, you know, behavioral profiles might actually be expressed differently depending on the origin of the person. And then can we intervene? Can we develop targeted interventions to actually better help the person to stay engaged in those activities that are pleasurable to them? How can we better support people to have purpose and to be active and engaged in daily life? And how can we support carers as well and ensure that everybody is living as well as they can and living well with younger onset dementia? And so being here is great because I'm getting to hear from the European Northern Hemisphere perspective, but I really want to emphasize that we're really open to ideas, suggestions, feedback, and we're very keen to collaborate as well. So please do feel free to grab me at some point or to email me. And thank you very much.
Thank you so much, Muireann, for this excellent presentation. I can only imagine there will be a lot of questions for you. We have room for one single question because of the time, but Muireann will be here to answer any questions later on. Is there any question in the room at this point? I see one over there. Can we get the microphone to...
Thank you very much for your talk. It was very interesting. I can imagine that there might be quite challenging to communicate about anhedonia, and something where it strikes me as a really good example of how you control the message of scientific research, because you put a lot of the headlines up. And if someone goes and looks up anhedonia and says, oh, can't experience pleasure, how do you communicate with people so that the message doesn't become, oh, well, people with dementia can't experience pleasure anyway?
Yeah,
So
and I think that's
communication challenge.
Yeah, really important point, because we don't want people to then necessarily give up and say, oh, well, there is no capacity there. So some of those headlines, everyone here will know when you disseminate your research, it can get really twisted. I think one of the main avenues that we're working on now is looking at the dimensionality of it. And while some aspects may be blunted, there is actually preservation too. And that's something I'm very passionate about in my research, is identifying the profile of sparing rather than trying to identify deficits only. And so when we work with our people with lived experience and their care partners, we're always emphasizing, to look for those things that may be preserved, and that's the target that we're aiming for, and then seeing can we widen, the fan afterwards. But yeah, I totally take your point on that.
Okay, thank you. A round of applause again. Thank you.
Good. So next up is Dr. Rianne de Heus. She's a senior researcher at the Alzheimer Center in Radboud University in Nijmegen, the Netherlands. And her research focuses on geriatric care, prevention, lifestyle interventions, but also post-diagnostic care and support for people with young onset dementia. And she's also the project manager of the national cohort of a national study, I must say, on young onset dementia in the Netherlands, the YOD-INCLUDED, which you will present today.
Yes, thank you, Marjolein, for the introduction, and also for the opportunity to present our project here. So I am the project manager of the YOD-INCLUDED consortium, so I'm standing here on behalf of the whole group, and in particular of the project leaders, which are Professor Koopmans in the room here, Dr. Bakker sitting here at the desk, and also Professor Pijnenburg from the Alzheimer Center of Amsterdam. So this is probably the first time that we talk about YOD-INCLUDED at an international stage. So I'm very happy that we can share with you what are our plans and ambitions for the next year. So briefly about the name, YOD-INCLUDED. So YOD is obviously for young onset dementia. And with the name included, we would like to express that we are very broad in the scope, so in our research aims and the points that we focus on, but also that we want to be inclusive in involving also persons with dementia and their families in the research program. And that eventually we hope that our research program will benefit all persons with young onset dementia in the Netherlands, and maybe even broader than that. So what are the key messages that I hope you will take away from this talk? So by combining our forces and working with multiple disciplines in this research program, we hope and also by taking the lessons learned from previous research, for example, from PRECODE, which Kirsten talked about, we hope to really accelerate young onset dementia research in the next few years and eventually make significant impact and improve the quality of life of persons. So the ambitions are high. So what am I going to talk about? I will start with a short historical view of the Dutch young onset dementia research so that you can get an idea of how this consortium was created. Then I will tell you about the consortium and about the work packages that we are planning to do. I will go a bit more into detail into one of the work packages because there's no time to go into detail in all of them, and we'll show you some of the next steps. So a bit of a history. So here you can see a brief timeline of some of the milestones that have been important for the Dutch young onset dementia research and that led to where we are today. And I want to highlight some of them. So in 2013, the Young Onset Dementia Knowledge Center was founded. So this is an organization that advocates for appropriate care and support. So they identify research priorities, they make sure that new knowledge is also accessible, and they represent currently 39 long-term care organizations that provide specialist care for people with young onset dementia, which you can see here, they are well spread over the country. The Knowledge Center issued in 2020 a research agenda specifically aimed on young onset dementia, identifying the priorities, and the research agenda was composed with experts from the fields, researchers, healthcare professionals, but also caregivers taking care of people with young onset dementia. The aim of the research agenda was to bring more focus into the research lines in the Netherlands. And in the year after that, we were very happy that in the National Dementia Strategy of the Netherlands, young onset dementia was also identified as one of the overarching themes, meaning that there would be funding to construct a consortium specifically aimed at young onset dementia and specifically aimed at the research priorities from the research agenda. And that's where we are today, because in January we started with our research program. So this was our group at the kickoff meeting in February this year. Already a large group, and I think we've even grown a bit more since then, because not all PhD students were appointed at that time yet. So within the consortium, we have all the 5 Dutch Alzheimer centers represented. So these are research centers affiliated to a university medical center. We have a University of Applied Sciences, Hogeschool. We have the Erasmus University, and especially the health economics group is involved in the project. We have 2 patient associations involved in the consortium, so the Dutch Alzheimer Association and the Association for Persons with Frontotemporal Dementia. Of course, we also have the care organizations represented, so the Knowledge Center is involved very closely, but we also added 3 other long-term care organizations to really make sure that their voice is also heard in the project. And last but not least, we have VLANS involved, which is a knowledge organization in long-term care, to make sure that everything that we will find is also disseminated and implemented. So an overview of the project. As I said in the beginning, the project is broad, so we focus on different themes. So amongst others, causes and mechanisms. And for this part of the program, we work closely to another Dutch consortium on young onset dementia, which is called YOD-Molecular. So really more about the fundamental research. Early recognition is one of the other themes. Accurate diagnosis. and appropriate care and support. And as the overlying themes that we focus on, we want to provide a supporting research infrastructure. And by that I mean that, for example, finding participants for your research can be quite difficult because especially certain subtypes of young onset dementia are quite rare. So we want to build a national infrastructure in which we collaborate and by which you can also find these participants more easily. So now I'm going to mention all our different work packages. So this will be a slide with a lot of text. One of our work packages is focused at genetic causes by studying families. So really looking if we can find any new mutations for young onset dementia. We have a work package focused on neuropathological properties by studying post-mortem MRI. So this means that for this work package, participants will be asked whether they want to donate their brains after their death, so they can study this. We have a work package which is actually also a follow-up of one of the work packages that Kirsten talked about from the PRECODE project, in which we look at the prodromal phase of young onset dementia at a primary care setting. So in this work package, they will, amongst other, look in registries of GP data to see if they can signal any signs or words or symptoms that are noted down in the medical files in the years before a diagnosis of dementia was made. There's a work package about the prodromal phase of frontotemporal dementia, where they will look more into new methods to detect the fairly early subtle changes that we see there, so that we could be detected earlier. And this work package is using an existing cohort study for this. It's called FTD Risk. And this is a cohort study running for many years already in the Netherlands, including mutation carriers for frontotemporal dementia. Then there will be a group looking at a clinical toolkit to better diagnose certain subtypes of young onset dementia, and to also implement this among all memory clinics in the Netherlands to reduce variation in practice that is currently occurring. There is a work package about improving the diagnostic trajectory at the memory clinic, but also the start of the post-diagnostic care immediately after the diagnosis. Because we know that there's a large group of people that don't receive any care or support in the first critical period after hearing the diagnosis. And there's still a gap, so we want to improve that. There is a work package about the evaluation of risky decision-making, and this is in particular linked to driving assessments, because currently a driving assessment is mainly based on memory and on physical abilities, but this group is going to look whether also risky decision-making can play a role in this assessment. Then there is a group looking at post-diagnostic care and support. So what services are currently on offer, what services are used, and how does this match with the needs and the preferences of people? There is a work package looking at needs-oriented psychosocial intervention. So based on what's coming out of the previous work package, where's the gap, and do we still need to develop something for this? And there is a work package looking at improving integrated care. And then I almost forgot one. That's the work package on the national cohort study for young onset dementia. And I will talk briefly about it later. I want to highlight 5 of them because the PhD students are present here in the room, and they also have a poster or a presentation today. So I can really advise you, if you want to know more, visit them after this session. And then I will tell you a little bit more about the national cohort study. So from PRECODE, we learned that it's difficult to recruit persons at a memory clinic because you have to have all the physicians involved. And we want to make a follow-up on the PRECODE study and set up a cohort where really the persons are in the lead of the data collection. So they can initiate their participation their own. And we collect a minimal data set every year, which consists of the 3 components, with a very dynamic component where they can participate in additional modules if they want to. And then I will quickly skip this because we're running out of time. But I hope you will hear from us in the next few years, because we only started this year, so there's many exciting things to come, I hope. Thank you.
Thank you very much, Rianne. A unique collaboration and highly ambitious. There's time for one question. Is there anyone? If not, yeah, in the back.
Hello, hello. On your list of priorities, I wondered how many of those were the priorities of people with young onset dementia, and if you engage with them, how did you do that?
You mean
in your project, all of the different elements, are they priorities of people with young onset dementia?
Yeah, so all the work packages that we will be looking at are based on this research agenda that was composed, and that was also composed in consultation with people with dementia and their caregivers. Does that answer your question? Or?
Yeah, thank you.
Okay.
Okay, another applause for Dr. Rianne de Heus. And for those online, you can ask questions in the Q&A of the app, so don't forget to ask any questions if you want to. Next up is Professor Jacqueline Parkes, who has a chair in applied mental health at the Faculty of Health, Education and Society at the University of Northampton. She's founder and co-lead of the North Hampshire Dementia Research and Innovation Center in Endrick at UON, and she has an extensive career. I won't mention all the topics you're involved in, but especially in young onset dementia, so we're very happy for you to be here. And you're assisted by someone who's not on the program, Dr. Laura Cole, a senior lecturer and course lead in dementia studies at the Geller Institute of Aging and Memory at the University of West London. And you're doing a duo presentation, so the floor is yours.
Yes, thank you everybody, and thank you Raymond, Professor Raymond Koopmans and Dr. Christian Peetoom for inviting us to take part in this symposium. I also want to thank my colleague Laura, who is assisting me today. Didn't necessarily realise she was doing it, but you know, we like to surprise. So you'll see why in a moment, if that's okay. Laura's going to give you some of the results of the study. It's a real pleasure to be able to present to you the DEfIN-YD project which we initiated at the University of Northampton. DEfIN is really catchy. I wish I hadn't called it this, but we did. So it's representative of Dementia Experts for Involvement Network-Young Dementia. The history comes out of the biggest UK national study, the Angela Project, which we are very proud of. In the UK, we had a forum for people with dementia to be involved in that project. There are papers on that if you wish to follow it. From that forum, we linked with the Young Dementia Network in the UK. There are some slides at the end, which you can get the information. And we had a conference in Sheffield where we looked at what are the topics in research that most people with younger onset dementia actually want to be researched. And in the UK, and I suppose it's true in many countries, to get funding, to work on research projects, we have to have and would want to have the voices of younger people with dementia or people with dementia involved in those projects. The problem is the sustainability of those activities. Often we recruit individual people, we support them, we train them, and then the next time we need a project and we start to design a project, we start to look around again for individuals. So the idea came from our conference in Sheffield of actually forming a network across the UK. So the project team was myself. I co-designed the project with Dr. Mary O'Malley, who you will see on the slides. And we had 2 research assistants. Shortly after the project, winning funding from the Wellcome Trust in the UK. It was a public engagement grant. Mary moved to the University of West London for a senior lecturer post, and very shortly after that went on maternity leave, and Laura joined the project as the co-lead from the University of West London. So Mary has now moved to the University of Worcester, and we are working with Worcester as well in this project. So initially funded in August 2019, it was designed to be face-to-face with 3 regions in the UK, the North, the Midlands and the South. The North, we worked with the University of Bradford. The Midlands was ourselves at the University of Northampton, and the South was working with the University of West London. We recruited people with younger onset dementia at the time of diagnosis, and that's key. And we actually launched the event eventually in 2021. There was a little something like a pandemic, got slightly in the way. It was designed to be face-to-face. The Wellcome Trust was very understanding, and we designed a project almost entirely from scratch that went fully to online. Until we had our event this year at the end of the project in July, and we came together for the first time in July, and I can see some of our members in the room. It was lovely I think I met Laura for the first time this July in person. We went from Zoom to Teams. Unfortunately, many universities in the UK at the time couldn't use Zoom, so we ended up in Teams. That was very controversial. We had 2 phases to the project. The first phase was developing some workshops, training the 3 groups. The 3 groups got the same approach, and we trained them in research techniques. We did 5 workshops, and then we moved into phase 2, which was an evaluation research project. So the aim of DEfIN was really to raise awareness of young onset, was to create this network associated with universities, and to understand if we could make this network sustainable. We actually finished the project on the 28th of September this year, and we're just looking at the sustainable model as we speak. So we had a launch event. I think Christian presented at that, which was lovely. And we've recruited people, as I said. We did the actual workshops. We had independent facilitators. We actually thought they wouldn't want us university researchers in the room, but they did. And we worked with them, and we began to capture their experiences of being part of a network. The third aim, as I said, was to look at the sustainability of the DEfIN groups, which I will come on to now, just after Laura, sorry. And the outcome of the workshops, I'll hand over to Laura.
Thank you, Jackie. So as part of one of the workshops that we did, so we did one with each of the 3 regional groups, and then we had subsequently 4 after that. And I think it was in the second of those groups that we started asking people what was their priorities for research. And here you can see our thematic groupings, really, of what that research was. So you can see there was a lot of anger in some which ways about the need for education and training from all people who may be dentists or GPs and anybody that works with people with dementia. So it could be anybody in the healthcare system or social care system. The other thing was the unique challenges of living with young onset dementia. So some of the challenges being because of the age of people. So whereas we may think of dementia maybe being for older people who may be retired, there's unique problems that people have when they're younger because they have financial responsibilities, people to look after, they have a job, and these sorts of things which make it unique. Inclusivity and citizenship, generally just maybe staying in a job or keeping within the community. And also some people were saying that they weren't included in dementia research because of their age, or maybe because they lived on their own and, as a younger person, and that excluded them from some of the research. And then the final one was the policy and practice that sort of encompasses all of this, really. So just take you through some preliminary findings very quickly. So what are we going to look at? So we had the launch event and then obviously the PPI group. So we're going to look at the processes that we went through to do those things and look at how we can make recommendations for others who might be trying to embark on similar ventures. We also we asked the researchers, so ourselves, we had a group discussion of everybody involved and to say what was our experiences, what do we think went well, what do we think maybe could be done differently, what have we learned. And then also we had PPI group reflections. So we asked people, the members of the PPI groups, what was their reflections? Because this was a process. We were all learning together. And so we wanted to reflect on that, so again, see what worked well and what didn't. And we're going to, we're in the process of writing those up at the moment. I'm not going to go into all of these details, but just you can see there's quite a lot on these slides. But the reasons for joining were quite emotive and did get me sometimes, but people finding a purpose in what they're doing, in being involved in this group, and giving meaning to their lives, to be part of this, a part of a community, was very... and a belonging that's very, very important to people. Some people had previous opportunities to be involved in research, so they sort of brought that with them, but other people didn't. So it was a sharing of, people who may be participants in a study or other people who've been sort of maybe involved in other types of research as well, maybe on designing and co-producing. So the experiences of people being in the PPI groups, mainly, I'm glad to say, was quite positive. There were some obvious issues, such we had, there was, obviously most people with dementia in the UK have been used to, particularly during the pandemic, using Zoom, and unfortunately we weren't allowed to do that for our university, so that causes some issues, and some of the ethics and consent processes, because obviously we wanted to write this process up, so we needed to go through that. But I think mostly people were kind of like, we've done this already, but as academics we feel that we had to do what we needed to do just to make sure. But I think there was some understanding on that on some levels from members as well. They were very kind to us and put up with some of those things. So I think that's that one. And then Jackie, I'm going to hand back quickly to Jackie for sustainability. Thanks.
Thank you, Laura. So finally, as I said, we finished the project on the 28th of September. We had our final launch event, and during that launch event, we all came together. We're in the process now of running what we call touch point meetings. It's the only time in a project I've ever had an underspend, and we found ways to be able to continue to touch, to retain contact with all three groups, so that we could begin to look at the sustainable model. We're currently having conversations with the Young Dementia Network. It is a national network, if you want to look at it and what it does. As I say, I'm the Deputy Research Chair on this network, and the idea came from the Young Dementia Network. So we're looking at them partnering with our groups. And we've worked through this year 3 different ways of looking how the groups might look. So we started off looking at whether the Young Dementia Network would host all 3 groups and it would come under their auspices. they can't do it that way round because of banking issues and things like that. Yes, thanks, Christian. We also looked at whether all 3 universities should do it separately, but we want to be a national network and have a national identity. So we're opting at the moment for the middle ground, which is partnering with the Young Dementia Network, but a local charity hosting and having a coordinator that pulls together these networks. We're looking at a logo. It was interesting, we had 18 logos, they want to choose the logo, and we're looking at the costings. But what's really, really interesting is how you generate income to keep these groups going, and that is still yet, I think, to be tackled both nationally and internationally. So that's the process we're in at the moment, and the project finally finishes in December.
Thank you, Jackie and Laura, for this excellent presentation. A lovely project, DEfIN-YD, hopefully inspiring for other researchers setting up such a project, but it's the same for all the projects discussed today, I think. Hopefully will be inspiring. There's room for one question in the room or online. I see 2 hands, so we'll have to draw the lady first, I think.
Take one, I'll take one.
Thank you. My name is Chris, and I've been one of the PPI members of the group. And I just wanted to say how important it is to get us involved right at the beginning of your research projects, because it's no good getting us involved halfway through. And I've so enjoyed it, and I'm still part of the group. But please remember to involve us right from the beginning. And as they say, don't do anything about us without us.
I totally agree. Thank you. Unfortunately, we're very tight on time and to allow people to join the next meeting, so we'll head on to the last speaker now.
Yeah, and that is last but not least, the Dr. Esther Gerritzen. Nice to announce you as doctor now, because you just finished your PhD in the Distinct Consortium on Technology and Dementia, where you focused on the possibilities or potential of online peer support of people with young onset dementia.
Okay, well, thank you for the opportunity to be here, and thank you for the kind introduction. So today I will present what came out of my PhD research, which was developing a best practice guidance on online peer support for people living with young onset dementia. And for this, I got the support and supervision of Professor Martin Orrell and Dr. Ori McDermott. And I'm very happy to see that actually some people who supported the research through focus groups, interviews, and by giving feedback on the best practice guidance are sitting here on the front row. So today, I will speak about, first, why did I look at this research? How did we do that? What are the outcomes? And then finally, what are the next steps? So first, why did I even start looking at young onset dementia and online peer support specifically? Well, first of all, why is peer support so important? As we have learned already through the other presentations today, people with young onset dementia face unique challenges because of their young age. They often have to deal with many losses, like losing the job, losing driver's license, losing contact with family and friends. And one of the main reasons for this is the stigma that still exists around dementia, and especially around dementia at a younger age. And this really can put people at a higher risk of becoming isolated and losing their role and importance in their social circles. So research shows that people with young onset dementia want services that respect their autonomy, their independence, and also their skills and abilities. And they want support that supports them and their families as well. So really what that shows is that people want a balance in the support that they get, support that respects their autonomy, but at the same time gives them the support that they need. And this can be related to the social health framework, which really looks at health and illness for us a balance between the abilities that someone still has and the disabilities or the challenges that come with living with a certain health condition. So this really formed the foundation of my PhD project. So when thinking about social health, peer support really is a form of post-diagnostic support that can support every dimension of the social health framework. It is a unique form of support that cannot be replaced by other people because it is that lived experience and that real understanding that only other people with a young onset dementia diagnosis can have. Like, as researchers, we can't give that. Family and friends, they can be supportive, but if they don't have the dementia diagnosis themselves, it's not the same. And the same goes for healthcare professionals. So that is one aspect. And peer support is really characterized by that experiential knowledge because someone else might have had the same challenges in their daily life or they might know where to find support. So it's that unique knowledge that someone has because of their own experiences. Then there is reciprocity. And peer support is a unique setting because while receiving support from others, it also enables people to give back to others. And I think especially with dementia, many people become increasingly dependent on others and they might not be able to do the certain things that they used to do or not in the same way. They might need increasing support for others. But through peer support, they can take that empowerment back by giving back to others and also by getting involved in, for example, research projects or other community groups. And then, peer support really offers a form of social support. It's not only about talking about dementia. Of course, that is an important part of it, but it's just also about being with people who understand, don't have to pretend. People know the kind of challenges that you might be going through. So peer support can happen in different settings, like it can happen in person. This is a logo of a memory cafe in Beeston, in Nottingham. So that is quite a well-known community-based peer support setting. However, peer support can also happen in online settings. For example, Zoom, but also Facebook groups, people with dementia connecting on Twitter, or now called X, or discussion forums, for example, the Talking Point of Alzheimer's Society. This research started in October 2019, so before the pandemic, but already then it was meant to be a project about online peer support. However, during COVID, the attention for online support and actually the need for online support became even bigger. So one of the reasons why we started looking at online peer support is because in-person specialized support services for people with young onset dementia varies a lot across the UK, and some areas have very good support in place and other areas have hardly anything at all. And especially this is also true for peer support groups. People might have a memory cafe in their local area, but if that is only attended by people who are maybe 15, 20 years older than them, this is not peer support, because peer support is really about sharing that level of similarity, that this can be age, type of dementia diagnosis, hobbies, work, it's so much more than that. So, through literature research, but also conversations with people with young onset dementia and professionals working with people, we found that, as I mentioned, access to specialized young onset dementia services varies widely, and this includes peer support groups. Also, when looking at online support, there was very limited research into how people with young onset dementia experience being part of online peer support groups. So there was research already out there on, for example, a content analysis of posts in a Facebook group or conversations in a discussion forum, but it didn't include research where people with young onset dementia shared their personal experience. And as I mentioned, the impact of COVID-19 showed that when all of a sudden many groups had to move online, it was almost like learning by doing. There was not really a protocol or anything out there on how to make that transition. So our study aims were to identify the facilitators and barriers to online peer support for people with young onset dementia, and to produce recommendations for people with young onset dementia and facilitators. And then this we wanted to collate in a best practice guidance. So how did we do this research? The project consisted of many different parts, and I will go into not too much detail on each because I would need an hour, so I will keep it very brief. But as I mentioned, we started with stakeholder consultations, and this included people with young onset dementia and professionals. And after this, we continued to a systematic literature review, and I wanted to do that about online peer support for people with young onset dementia because that seemed the obvious choice, but the reality was that there was just hardly anything out there. So instead of that, we looked at online peer support for chronic and neurodegenerative conditions that share similarities with young onset dementia. So I included Parkinson's disease, multiple sclerosis, and motor neuron disease. After this, we decided to take it back to young onset dementia. So we took the findings of the systematic literature review to establish the focus groups. And one of the main things we found was that the level of similarity is so important, and that if people feel a bigger connection with the group, they're more likely to stay in contact with the group and to continue. And also sometimes simply reading about other people's experiences in an online platform can already increase feelings of connection. So the focus groups, we did 4 focus groups across different parts of the UK, including 20 people in total. And these groups were all online because they took place during the pandemic, but actually it was very beneficial because I managed to have a focus group with people from Scotland, people from the south of England, and that wouldn't have been possible, or at least very difficult, if it wasn't online. So from the focus groups, we found that some groups were in-person groups before, and they moved online because of COVID. And in those groups, the feeling was really like, online is better than nothing, but we can't wait to be back together in person because there's just, you can't replace that real human connection online. We also had some groups that were online-only groups, and there people spoke about the benefits of meeting online because, for example, they were not able to travel to an in-person group, or they had anxiety about getting out of the house and going to new places, so they actually preferred being in their own house in a comfortable environment. So next, we did an online survey because the focus groups were only with people who could use Zoom and who were already part of a peer support group, but we also wanted to include the views and opinions of people who had never used peer support before or online support. And we found that one of the main reasons why people did not use online peer support, it was not because of technical challenges or because they were not interested. Most people didn't know that it even existed, or they didn't know where to look for more information and on online support specifically. And interestingly, of all the people who had never used it, the majority said that they would consider using online peer support. So I think that was one of the main interesting findings. And also we found through the focus groups and online surveys that the known benefits of peer support that I just mentioned, they're also present online. And then finally, I did interviews with people who took part in the survey to get a better understanding of why some people were hesitant to engage in online peer support. And the main finding that we found was that people are a bit hesitant because they are not sure what to expect from online peer support. Sometimes the group description can be very brief and doesn't say so much. And people are also worried to see others who are maybe in a different stage than they are, or who experience more severe symptoms. So from that, we took that having a very clear description of the group and maybe having a one-on-one conversation before someone joins the group can be really helpful in taking that anxiety away. So I will finish quickly now, but all these studies informed the best practice guidance that we developed, and it was in that way directly informed by people living with young onset dementia. So then we did another stakeholder consultation where people with young onset dementia and professionals gave feedback on the first draft. We developed the second draft, and then again we discussed it within the team. And this went to the final version of the best practice guidance, but I must say it's not really the final version because this is something that will always stay in development, of course. And in the outcomes, I will say that there's two parts. One is for people with young onset dementia, really stating what it is, online peer support, what can it bring someone, what are the different options for online peer support that exist, and really hints and tips on how to cope with some of the technological challenges that people might experience. And for facilitators, we looked at how can they best support people in finding the right group, how can they best support people during and after and also before the meetings, and finally some hints and tips on like running online groups for and together with people with young onset dementia. So like I said, we're currently refining the best practice guidance and in the process to make it publicly available. And we also want to see how can we improve the availability and accessibility of online peer support, because now after COVID, many groups went back to in-person, but how can we keep that online support active? And yeah, I'm still also working on post-diagnostic support more broadly. So, well, these are some of the references. So thank you. I also want to mention one thing. If you are early career researchers and you want to connect with other early career researchers in Europe, there's a link where you can connect. So, yeah, that was it.
Thank you, Esther. So maybe one short question for Esther would be nice, and then we finish. Yes.
I'm living with Alzheimer's. I was diagnosed at the age of 55, and that was perfect. Because where I come from in Scotland, if you're under 65, there's absolutely nothing. And for people, for researchers to contact people like ourselves is where you should go. With the people who have the dementia, we're living with it, and we know what it's like. And peer support is probably the most important thing that you can provide for somebody with dementia. It works. We've proved it works. It saves lives, and the research was amazing. Thank you.
Thank you so much.
Thank you.
Thank you so much for being here at this Interdem session, and we thank Interdem for making this possible to have a session on young onset dementia. I have one household thing to say to you. If you have registered for the welcome reception, the organization wants to stress that you have to be in time for the bus transfer, so you won't be able to go to the city hall. So you must be on time. But you'll hear this in the next session as well. So thank you for being here, and thank you for all the speakers. One last applause. Thank you.